This is a podcast where experts in movement and life tackle current concepts in health and wellness and use science and evidence as the foundation of how we discuss each topic. This is not medical advice, but a sedentary lifestyle is much more harmful, so we should move. The Motif Experience, where movement and life come together. I'm your host, Dr. Tyler Cuddeford. On this wide-ranging podcast today, we have a number of guests with us. Jeff Houck, Dan Kang, and Andy Meszaros, Crispy Bacon. And we're doing a Mythbuster segment today. So the idea is to tackle some of these current concepts that have no scientific foundation or very little scientific evidence. And so I think you'd be really interested in, when we look into the research, what kind of value these particular treatment approaches have. There's no window in that door. I don't think there's a window in the door.
So I think we identified somebody in our second year that cannot relax his back and would fit perfectly for the thing that all three of us have been talking about, but Andy's been really trying to hone into the relaxation component. I don't know if it's relaxation, but like distraction. Yeah. There's a person who already gets exacerbations in his low back regularly. He's been having back pain for 10 years, and his active range of motion was normal. Yeah. But his every P-ROM, passive range of motion, he was fighting it, and he had pain with each P-ROM.
So get this, Dan.
It's Mason.
You know I've had off and on for ever since I herniated my disc. Right. Because this idea of lift, always when my back kind of gets all a little tweaked, I always went to stabilize the core, baby. Yeah. Right? Yeah. Excite the abdominals, lift, do everything like that. So we're getting ready for the wedding, and it's just manual all day, in the summertime, and got twisted a little bit wrong, and it's just like, dang it. And so, I've always kept working, but sometimes it just gets more flared up and more flared up, right? And so this is so true. I said, okay, this is how I'm going to lift. And I went like this. Belly out. Just like what you teach. Yeah. I said, belly out. Because you can't stabilize the core when your belly's out. You cannot fire the abdominals or the back extensors when your belly's out. Yeah. So I just went, stuck my belly out, and then I just started lifting like this.
Come on.
Nothing.
Yeah.
Usually it works, sometimes it works itself out, but it's a couple of weeks. Sometimes I'm gapped. Yeah. This time, nothing.
And it worked.
It worked. Yeah. Because I was the same. Yeah. Get the back tight, tighten the abdominals, get it stabilized so that, because that's the stabilization theory. Yep. You get it stabilized so you can lift. Yep. I was the total opposite.
It's 100%. And
belly out.
It's interesting because Josh was the one that was Mason's partner, and he did the P-ROM. And he comes to me and says, I'm so freaking confused. His A-ROM is fine, but every single P-ROM, he complained of pain. Right. And so there were students were saying, well, do we really need to do P-ROM? Yeah. I'm like, there you go. And I said, why do you think he has P-ROM is tight? Or why he's complaining of pain? And they're like, they didn't know, right? I said, protective mechanism, right? He's been having pain for 10 years. Yep. And he's trying to protect his back, right? I believe it. And I said to him, I said, Mason, you do CrossFit? He's like, yeah. I said, your back's already strong. How do you feel about that? He's like, I love it. Keep talking dirty. Right? And I said, how about if I said to you that you actually need to relax? Because the last time that my back went out was actually an anatomy. Like really bad, because I was leaning over the table. Right. And I said, let me guess, you're tightening up your back. He was like, I don't even know, because when you do P-ROM, I don't even know that I'm actually like fighting you. Right. But you can feel it, right? It's like, you're doing, it's like, relax. And it's like, he can't relax. And I said, how long have you been having this for? It's like 10 years. And I said, we found somebody. I said, this would be a perfect case study for us to follow through deeply. Because I think he fits it, because he's a young guy, 10 years of back pain, always has an exacerbation, and like every couple of months he says, it doesn't matter. And I think it's because he's just, his back is tight and strong, so.
So what would you do for him clinically?
I would first start with education and actually like helping him recognize how strong his back is. Right. To help, it's not even distract. It's to allow him to like have a new framework around like, okay, I gotta tighten up my back, instead of saying like, hey, my back is strong. I do shit to it all the time. Like I lift. So I may then teach them, I may have them like see how much he can lift for a bit. Just to have him give me nonverbal that he can do stuff. And then what I'm going to do then is figure out how I can decrease like his focus on his back and maybe just moving, right? Doing something. And I think that's all I do. And then teach them that you can actually have strength when you're lifting, but you don't have to focus on your back being always super tight. I don't know. I mean, that's what I normally do with the patient. Sometimes if the patient can't do that, you have to go to the very basic of like having them lay down and just relaxing their back for you. And they say, what does that feel like? And they're like, oh, that's relaxation. I said, well, can you stand up and see if you can do that in standing position? Because a lot of times what I notice is that they're always going like this. And they don't even realize they're trying to always do that. So the science around it, the only thing that I've been able to see is I always try to talk about that flexion relaxation curve thing, right? When you put EMGs, but the gap or the literature on this is pretty high right now on like what you do. So what BPS people always say is just do mindfulness stuff, like practice breathing. I don't do that. I think that's actually too passive. I try to expose the patient with movements, but then also reinforce like what might be occurring in bite-sized pieces, right? And so that's why it takes usually 2 or 3 visits, because I think real learning doesn't happen. Like one-time visits can happen, but it has to be very, very simple. Like the concepts have to be so simple, and the person has to be somewhat, like it has to match their intelligence and their soul, everything. It doesn't always line up like that. It usually takes like bite-sized pieces, and then once they get the concepts, they have to take it home and play around with like homework, and they come back, and then the homework becomes the driver of the next treatment. If they don't do their homework, then you have to go back to the basic, and that usually occurs for about 3 times. And if they don't do their homework after 3 times in ortho, they're usually, I'm going to cancel, or they're done. And then you give them time to say, you can come back anytime. But that's what I've seen like in clinical practice patterns over the 20 years, like what I've seen. So the first thing I try to do is I try to hook them. Like I just try to give them that first hit of like, oh snaps. If I can do that, then I know that it's going to be, it's going to work out. People call it therapeutic alliance. I don't think it's therapeutic alliance. I think it's like this deep-seated like hope and tree, like curiosity from the patient. Therapeutic alliance is like, oh, you like me, I like you. I think that it has to be much deeper when you're like Mason. He came up to me and goes, dude, when you told me that my back is strong and that it's like you see me trying to protect it and you embarrass me from the whole class, he said to me, Dr. Kang, thank you so much for not embarrassing me. Make me feel like, like there's something wrong with me. And I think that's empathy, but it's also like showing someone respect for their shit. You know what I'm saying? And it's like, I never make someone feel bad because they're like, hey, wow, look at this. And then like they pull out a dime and a nickel. And I'm like, damn, dude, you got 15 cents. It's awesome, bro. Right? It's like, that's okay. But some people be like, oh, you kidding me?
That's all you got?
Yeah, exactly. Bitcoin, It's like, fool, come on, man. It's like, let me take you to the school. And I'm just looking at him like, you're an idiot, fool. Yeah. Don't. Just say to them, that's like 15 cents. Good for you. Right. It's like close to a quarter. Let's get another dime.
Yeah.
And I think that's what so some people come in, they got like, the hardest ones are like, I got nothing. Because then they go like, I got nothing, and they've been there for a long time. Right. It's like, my identity's, I got nothing.
Yeah.
So then they're too prideful to ask, or they just don't know how to get. The easier ones are the ones that get like 5, 10, 15 cents, and they recognize they just need to get $1, and then they need to get to $2 and $3, and then they can build up. The other people who are hard, who are millionaires, who they don't know how to cut. They're just spending, and they don't know. So I always look at these different analogies of like how people are seeing themselves. So Mason's got 15 cents. We just got to get him to a quarter, and then he's going to stack it. He'll stack it quick.
Don't you get people that are angry because they're doing what their therapist told them to do with the whole stabilize the core thing? Like, I mean, because when they figure out that you're telling them to do the opposite of what the therapist told them, I don't know. That has to be.
We see that in the clinic.
Unsettling,
so, especially I don't know about recently if you've seen that, but there's a lot of times when we're the last resort. They've seen everybody. They've had 20, 30, 40 visits of PT, chiropractor, and then they come see us, and they're a bit angry because in 3 visits they're completely pain-free.
Yeah,
and they are angry.
But I mean, before they get to,
but see, they don't know
the third visit, like that has to be hard on them or confusing. Like, wait a second, I'm doing the opposite of what another person licensed in your profession told me.
Yeah.
And I could see where they could just like, fuck it, you guys don't know what the hell you're talking about, right?
Yeah.
Eat butter, eat margarine, screw it all.
Right.
Yeah.
You know?
Yep. Yeah. And
Cool. So the data out there says that they like their PT, so they don't confront them. So when they come in, they're not going to throw the PT under the bus because they've seen them for 37 visits and now they're the friend. That's a problem. Where if it was a physician, they're going to say, "Doc, it didn't work." Right? But they're not going to say, because now they like the PT, and that's clear.
So maybe we shouldn't be friends with our patients.
I'm a big fan of one-time treatment.
I don't know. I'm wrong on that because you're talking about going deeper for trust. And on the other hand, if you get in too deep, are they really going to tell you what they really think?
So I think, it's at multiple levels, like we're always talking about, is about relationship with our patient, and then how do you give them a second opinion? How I usually normally say it is just I give them a second opinion,
right,
and they can decide from there instead of saying like, shit, crap it on the first
one.
Right.
Yeah, sure.
Bashing the
right. But I do let patients, allow patients to talk about how discouraging the last therapy was.
Yeah.
And I let them run with that for a minute, and then I usually then will either apologize for that, or and say that I personally didn't have anything involved, but it is the profession I'm in, and I apologize for that, the hardship that you went through. Do that, and let's try something new.
I've seen that work really well, especially for those that have gone through long-standing bad treatment. I'm sorry that they missed that.
Yeah.
I'm sorry that you went through all of this, and you weren't better.
Yep.
I think that worked. But see, Dan's relationship, though, with it's not a friend.
Yeah.
Right. It's immediate after a visit that they can trust Dan. They know he's going to go find it, and that's the relation. They know he's going to follow up because he does. He texts them the next day,
right?
Or has a student do that, and I mean that's not necessarily a friend.
That's credibility.
It is. It's putting your money where your mouth is.
Yeah. They have the sense that Dan has skin in the game with
Dan
them.
right away. Dan's a part of that, and he has skin in the game.
And that's different than being a friend.
Liked or a friend.
Yeah.
I think they like him, but that's not the point.
Because do you broadcast to them, like, you're not just in it to be popular. It's not just I want to be your friend sort of thing. Because you're going to ask them to do things that they don't want to do, and that's hard if you're a friend.
Yeah. I don't broadcast anything about us. It's mostly about the patient's experience in the beginning, and then it's just like a good coach. You just start making adjustments together, and they think that it's them that's making the adjustments, right? But it's really the coach that sees like the playing field completely. It's like you can see the playing field. You're just asking them to maybe make adjustments that no one has, and those adjustments are really, really powerful as you start making those positive moves, because by the time they see us, the pain is starting to drive them a little bit. There's concern. They've
reached their end.
Yeah. That worrisome, and that's the psychosocial component. But it's not the psychosocial that people think. It's not just full depression, anxiety, and we know that because we do measure that. It's more the concern that they have from pain. It's like, will I be able to do my stuff again? And then that question is not
right now I can't.
Right. And so we don't give them false hope and say, if I do this procedure, you're going to have hope. It's more like, let's dive deeper into that and let's see what the evidence looks at. But here's my clinical reasoning or practice around this expertise. And I think the back is pivotal because you need to know your stuff around the back. And I think a lot of people think they know, but they really don't. And it comes out as you start seeing the practice patterns and how the patients are behaving. Because the back is so multidimensional, it's easy to kind of see like where the transitions weren't very good versus something that's just straight anatomical or biological. Let's take an ankle. It's hard to mess up an ankle sprain, really. If it's straight mechanical, it's really hard to mess it up. Like in my career, even a total knee replacement, it's kind of hard to mess that up for a rehab standpoint. Mm-hmm. But the back, you can mess that up in a heartbeat because it's so it's different, right? And we understand that, and that's why the best thing we have now is the BPS. But I'm hoping that it will continue to change. That science and what we're researching will help us understand even better, like what the patient's experiencing. That's why people are big on like bio and neuro mixing together for this, and people have added psychology and social work. But at the same time, we understand there's these frames that we have to take into consideration. So as you guys all know, like I'm coming back to the bio and making sure we're not missing the mechanical part, because everyone's giving them all the psychosocial components, which I think is a great attempt to try to figure out this multidimensional approach. But at the same time, if you look at a physical therapist we can do the bio very well. I mean, research has shown us that the only person that does bio better than us is actually orthopedists. Everybody else, even other providers, physicians included, PTs are the second highest ranking when they do case studies and they watch and they observe and the way they follow the clinical practice rules. But this is the thing. We're not as good maybe in the psychosocial components, but let's take a psychologist. They're really good at the psychosocial components, but their biology may not be that strong. And so we have strengths that we offer, but we're also figuring out how to train these other things that will help the patient and for us to understand the complexity of low back pain. And I think that's where we're heading towards when it comes to back. And I think it's very exciting, but at the same time, being academic, I think that we're really at we're kind of at a very pivotal point that we don't want it to swing too far the other way. Mm-hmm. That we have to recognize that it should swing, in a way that is meaningful for the patient. Because I'm getting a lot of patients who say, only thing my physical therapist did was talk to me.
Yeah.
Right? And then that's concerning because we can do a great evaluation. I posted something online about how do you get someone's buy-in. I said, do the best and thorough eval possible. I got no love or no response because that's not trendy right now. Mm. You know what I'm saying? Because that's not Instagram famous to say that. Right. Give them the best freaking eval you can possibly give, like an objective eval to make sure you don't miss it.
So what is Instagram now?
Oh, you just, talk to them. You reframe what they say, you throw it back to them in all these approaches. And what I'm recognizing is like that's where the shift is becoming. And so we're kind of balancing it out by kind of going back and making sure we're being thorough with the evaluation process. And I love how Jeff said it to me the other day. He's like, we've always been about the bio, baby. Right? It's like, but what's Instagram famous now is like reframe why they don't want to be there, figure out the motivations. And I'm like, well, how about nonverbal communication? How about you give them the best darn eval they've ever experienced from a verbal, but also nonverbal, right? Like what you're doing. So you can explain to them, because I think where the moneymaker is really the assessment. The assessment is like where the money's at for us as therapists. Like,
I would just say, I'm coming in on this, but if you're saying it's on the assessment, I would say that would be a surprise to most people listening to this, because they would say, oh, it's in the treatment. They would all say that, and it's like they want to move to treatment immediately. Like, and are you saying that? Let me just ask you this: are you saying that because, like, that article we just read together on value-based goals?
Yeah.
Right. It takes. I mean, talk about that study, Dan.
Yeah. So the value-based goals study by Tanae Gardner, right?
Yeah.
Out of Sydney, Australia. Yeah. She does a lot of work around patient-centered goals, and what we figured out was with the patient's like number one goal when they choose, you might think it might be pain reduction. It's actually not. It's actually around physical activity.
So this is chronic low back pain patients.
Yeah.
And
you showed it to me yesterday.
Yeah. 70% of the patients identify physical activity and at least one other goal related to emotional distress. Yeah. But they also gave them the opportunity to identify pain as a goal.
Sleep.
Nobody identified pain as a goal when they were given time to really talk to them and reflect on what's important to them. And when you just change the conversation, instead of saying, "Oh, what's your pain? Da da da. Where'd you run?" If you change the conversation to what's important to you as a person, and then just let them talk and take 20 minutes to talk to them in a way using motivational interviewing, counseling, skill style things. So it takes some training, right? But essentially, what happened? Talk about this study's remarkable, really.
I'm not sure what happened. Sorry, I gotta go way other.
But they essentially identify goals. Only prescribe physical activity as exercise. No home exercise program compared to a standardized home exercise program, which all the other control group was given, and the patients who don't do any exercise, only do physical activity, lifestyle changes, do significantly better in a chronic low back pain population. Then
significantly better rated as pain,
disability, and what was it? Pain?
I think pain.
I think pain was the other one. I'd have to double check, but I'm pretty sure both. And
ODI,
but way like not. These are large effect sizes, not small effect sizes, right? And so it's. If you go back to the idea that the home exercise program is our product, everybody's like HEP, right? All the students exercise, everything. Like, why don't we just exercise? Why do we need assessment, right? It's like value-based goals is connecting with a person in a different way. We're not just, people dialing in the widgets of their physical ability. Like, I'm going to give them a little more strength here, a little more mobility here, desensitize them here. They're people.
Who could have prescribed this better? Because this is a great segue into treatments.
Yeah.
Right. So we're going to talk about treatments today. I've got my T-shirt, and we're going to talk about Mythbusters or busting myths related to treatment. Because I think there's some out there that in the way that I don't know if you're familiar with the show, but I watched a few episodes, don't know a lot about it, but they're not bashing people. They're just technically trying to figure out if it's a myth or not. Yeah. And so the intent really isn't to start just bashing people or doing these, but just draw light into, a practice pattern that, is on the edge and may not have a ton of evidence. And so we'd like just to kind of talk about that. Because I think people, it's actually a great segue. We didn't even talk about segues, but people think that it's the treatment. And so we're going to pick some treatments and talk about them and see why people get better with these treatments that seemingly don't have a lot of evidence,
or maybe some that have growing evidence that are interesting, right? Like dry needling. There's a brand new paper on JOSPT which shows dry needling does pretty good, really. Yeah, in terms of pain relief.
Right.
For shoulder anterior pain.
So
yes.
And I know that would be a hot one.
That would be a hot one. If you want to start with the hardest one or the hottest, we're going to dry needling.
But we can talk about that.
Well, I think if we're going to talk about it, we should acknowledge there's some evidence that it does really pain.
It's quite clear. A recent systematic review also said the same thing. Yeah. It's just as effective as other modalities. So we have to say that because the research does say that other modalities. So
also in this case,
the most recent one said it did better with anterior shoulder pain than other modalities.
I just looked at the one graph in there and I says, well, I'd rather be in the intervention group if I were in those two groups. And the one. Yeah. That graph was clear to me. It was the one group got manipulation, some mobilization techniques, and then the other one got the dry needling, and the dry needling was clearly the group I would have rather been in, or my parents or myself, right? So, so that
But how do we reconcile the fact that a dozen others didn't show that? See, that's the challenge, though. With So if it were a clinical practice guideline, it would get a D. Because it's mixed evidence, right? So you have to have a preponderance of evidence. So I'm not sold yet, just on one. I'm acknowledging that was a study that showed some value. So I'm going there. Well, we have to just not buy the one and forget the hundreds of others that didn't show that.
So, I mean, it's a newer technique, and so to me, one of the things that's being worked out in the technique is dosage. Like, to me, the most remarkable picture in that study is the number of needles and amount of electricity that's going into that person is like remarkable. It's
pretty phenomenal,
right? I mean, that's a lot of stimulation. But my point would be is that there's cost benefit and focus of PT direction. So I think emerging, the dry needling approach will probably continue to emerge because it's shown some potential.
Yes.
So dosage is part of the question, and so that'll be what's figured out next, right? Because clearly there was, like you were saying, there's other studies that have shown benefit, and I'm not an expert on dry needling, but
I'm not either. I've read a lot about it, though.
But there was one other one that I thought was interesting, was in total joint replacement, and they did some dry needling in people who had chronic, persistent symptoms after their joint replacement. But I thought that the thing I thought it was interesting is really they showed some benefit of dry needling, but it was only a very small subset of patients. So.
Right.
So basically, if you were doing that, the effective group would be not very large.
Right.
And so the issue to me is
that's a great point.
It seems like to me like a technique that is good, could have some benefit for pain. They'll figure out the dosage maybe.
Yeah.
There'll be some kind of application to it. But in terms of focus of PT, it's not helping us like in a big picture like cure a disease.
Right.
And see, I think
it seems to work well
or eradicates a big health problem. Like it,
right.
I mean, admittedly some pain things are a problem, but it's like as PTs, like where we may have been off focus is like as a group, can we start attending to or addressing major diseases or major problems like preventing chronic low back pain. And maybe dry needling becomes part of that, but it's like the bigger focus should be how do you prevent that? So, or, why aren't we more engaged in the discussion with diabetes and either reversing people with diabetes, because they really have significant problems, and, being part of that movement to me would be better spent on our efforts rather than developing
these micro things.
Hyper kind of focused interventions that take a lot of effort and equipment, right? And so that would be, I would rather have us shift there. So that's, to me, that would be more, it's kind of philosophical, and opportunities need to be generated, like primary care and these kinds of things. But those would be, that would be my thinking on that. But,
So two things that seem professionally unhealthy. One, like people will rag on like diathermy. Okay, we don't do diathermy anymore. Where's your book? Right, your 1920 something.
1928 book on physiotherapy techniques and treatments. Right here.
Diathermy for low back.
So in 30 years, dry needling could very well end up in this book. And what bothers me is, one, like I would want to know what is the prolonged effect when someone's moving. So passive types of treatments should play a limited scope.
Right.
The second thing is,
yes,
are you really going to leverage and advance your career by sinking your Con Ed money and time into a single technique? Because when all you have is a hammer, the world looks like a nail. Like everything looks like a frickin' nail. And I think that is a huge problem in our profession.
It is huge. I'm with you.
Because here's the deal. When you enter the healthcare arena, your choice of where you enter, I would think, dictates in large part what's going to happen to you. You don't go.
I mean, if dry needling's like popular now, you're going to keep it going until you're 40.
The point I mean now is, if you go to a surgeon, you have automatically increased the chance that you're going to have surgery. Instead of a surgeon saying, "I don't deal with this, but here's PT." But if you go to a PT and they happen to be into dry needling, You, by just your blind choice, knowing nothing about this, have in large part dictated what your treatment is going to be.
Yeah.
And in an ideal healthcare system, that would not be the case. Wherever point of entry you go, you should end up in some spot or a similar spot where your treatment is. So I think we do ourselves a disservice in the long run by still having this idea that we're going to invest in.
Pick anything.
Can I just comment? So I think what you're really saying is there's like diathermy is a good example. It's a phenomenal. It wasn't ineffective. It causes heat. It causes
great.
people to relax. They sweat.
Right.
And so these are phenomenological treatments.
I'm glad you brought that word up. It's 100% true. Here's diathermy electrodes for osteomyelitis.
Oh, that's interesting. That's an infection, right?
Yeah, that's an infection. I know, right? In 1928. Yeah.
So, but let's just stay
phenomenological.
So if you take manipulation,
yep.
Dry needling, there's another Graston. They're all phenomenological things that have these effects that are strong. They're all very strong. I mean, manipulation can wipe pain out instantly and like cause muscle relaxation. So those are really strong physiologic effects, and I think they all kind of lump into one category of phenomenological treatments. I mean, you can apply them to a person and get a certain phenomenon to happen, right? And so, if I understand you're right, what you're trying to say is it's like if we're kind of married to phenomenological treatments, then we're really not. We would have we're not really addressing the main problem, or we're not really, being accountable for healthcare kinds of things long term. But it doesn't mean also that we can't use phenomenological treatments sparingly to kind of get certain effects that we need. And so that's the same thing. Right. That's the same thing that we did with diathermy, right? I mean, it's like, of course, we're not using it anymore, but that's fine. But it's very, it's not getting us to the end point, right? And I think what's interesting, though, is like in all of that, you also have like this brand new paper from JAMA, right? And I want to go there just for a minute. Brand new, like what's the conversion that everybody should read? Like everybody. Like do you know the author? I don't know the author right now. We'll have to put it up online. But it's basically, it's one of the first papers I've read anyway that correlates the risk of chronic low back pain, what the risk factors are for going from acute to chronic.
Yep.
So, and it's this new area that a lot of people have been studying, and now the papers are just starting to come out. I saw another one too. So these factors that convert somebody from acute to chronic, we should all be paying attention to this stuff, right? And so essentially the two factors that were predictive, one was the start back categories of risk. So that immediately validates this idea that, that tool used early in low back pain, kind of acute problems should be utilized because it's helping who's at risk. And then the second piece was what they called discordant care with clinical practice guidelines. So the idea that clinical practice guidelines weren't being used. Those are the two biggest factors. And
there's three things that was discordant, right? It's the use of imaging, opioids, and then also with referral to specialists. And so it's not really clear, like, okay, so PTs have some like wiggle room there because it's not clear. Are we the specialists? Were orthopedic surgeons the specialists? But my thinking is we're in there. So it's not 100%, right? But it's like, and if I kind of think about things that we say to patients that are very similar to like imaging, like you have a backward sacral torsion, or your facet is stuck on the left side, or your rib is your quadratus lumborum isn't firing correctly, and all that. That isn't dissimilar to an imaging finding that's negative, right? And so I think that it's important for us to step back and say, hey, why should we really be this deviant from the clinical practice guidelines that we have that are quite well thought out and strong, right?
that currently exists for low back pain, and should we really be, kind of freelancing it for the benefit of these, getting some phenomenological treatments or whatever we're thinking about, at the risk of having a few people, because we want that so badly, right? For that a few people are going to end up with chronic low back pain because we don't have the discipline to use kind of more compliant, kind of guideline-based care. And I think that's really a good question for us.
Yeah, and I think the thing that's interesting was that the non-adherent compliance to the clinical practice guidelines for them, it was rampant with one. So you can get all three or you can get one, but even if you got one, I think it was like over 50% of the time they got one, right? But the other thing that we know from like how back pain is taken care of is the fact that physical therapy referrals have only stayed at 20% for the last 20 years. It hasn't changed at all. We know that. But low back pain has actually increased in primary care. So what we're seeing is that the first line of defense really is NSAIDs, advice to stay active, to keep moving, to not do bed rest, and then it's some form of exercise. And physical therapy is part of that, right? As the first line of defense. But we're not seeing the referrals going to them. What we're seeing, though, is an increase, especially to injections. Injection care right now is really rampant. And the other thing, too, is because opioids are decreasing in a bit. Yeah. And we're also seeing, so that increases specialty. X-rays in general are going down, but MRI is going up.
More imaging.
So those are the two things that we're seeing that's increasing in our thing. I think the other thing that I like to talk about, kind of like flipping back, is the understanding of prognosis for something. If you look at shoulder anterior pain, right, what was done 20 years ago was some type of acromioplasty. And now it was injection. Now we're saying dry needling. But what is really, anterior shoulder pain or shoulder pain anteriorly? So you got to think about the prognosis. I don't hear physical therapists talk enough about assessment and prognosis of a disease process. Because if Jeff is right, that he wants to take out some type of disease,
right?
And we say, hey, we're going to take out shoulder pain, anterior shoulder pain. That's not a rotator cuff tear, right? And we're going to take out low back pain. See, we're not talking about prognosis. We always talk about treatment. We're not talking about assessment. We don't understand that. But that's something that's biological in a way, and something that we can study straight through. If you think about dry needling for total knee, come on. It's the surgery's already been done, so we can pain modulate. So what we're talking about is modulation of pain, modulation of something, a belief of some type of control back. But again, the prognosis of anterior shoulder pain is actually pretty good. So, and same with the acute low back pain.
So let's just jump off here. So Ann Thackeray from Utah just published this last year. What are some of the main reasons patients don't come to PT?
Yeah.
And I don't know if you saw that article too, right? Yeah. So that article had, transportation, costs, these things and what if you paint a little different picture? So it's you say, okay, so rather than investing in modulation treatments, dry needling, all these kinds of things, what if we spent more time on redesigning our delivery patterns to address access? So you said, because we want understanding prognosis on many of these things is good already, right? And assessment so that we could know, okay, who's at persistent risk that needs more? So then we set aside those people to do more delivery. People who weren't at risk, we minimized what we do with them. And then we designed programs to have access. So we just got through with COVID. And so, we're in a rural health situation right now. So what if our delivery pattern was a combination for a bunch of different patients, a combination of telehealth, home visits, right, 1 day a week, and then also in person, because basically that would address access, right? And then we combine that with primary care visits where we see people just once or twice. And so we suddenly now, instead of going to where we're a provider who's kind of a hyper specialist, because we're so specialized now, we see 10% at best of a particular problem. So 1 out of 10 people who could benefit from us see us, right? And that's not a very high impact, or high value item to a health system. If you just do it at a system level, how can a group of people that only see 1/10 of all the people with that problem sit at a table and claim, that they are important to the system.
And I think you're talking about this glass ceiling, okay? So what you're saying is that physical therapy now would actually change like our clinical practice. Yeah. And what I see a lot is that we have this glass ceiling that we keep hitting.
Yeah.
You know what I'm saying? It's like reimbursement. It's about like having, what is it, when you have access to a health group or a hospital, right? You have this ability to see patients. Our profession, if we look at our tradition, was to help people with polio. It was treatment-based, rehabilitation-based. And what you're saying is let's raise the roof and let's open it up, right?
But with polio, it's interesting. It was needs-based.
Yeah.
Nobody, all these people had this muscle problem. And somebody had to come along and figure it out.
That's right.
So it's need. And so that's our root, right? And so this is the same thing. What are the needs? And so instead, we have the need.
Yeah.
Like 90% of the people with low back pain, we're not seeing.
Yeah.
So why aren't we adjusting ourselves so we see, 30%?
But who were the...
or something like that. Right?
But who were the providers still that said that we have a need and we need to train someone that does something different, though? Who were the providers who were like saying, dang, I don't have enough help?
It's the doctors.
Yeah.
Right? It was in the polio group, it was the physicians.
Yeah.
In primary care, we've been in there for now 3 years.
Yeah.
Right? It's the physicians that are overburdened, right? The quadruple aim, they're out.
Yeah.
The primary care physician is tapped.
They're tapped out.
So so when we were listening, that was it. It was like that they were asking for someone to come in their wheelhouse and provide care.
But we need to see ourselves as having a symbiotic relationship with physicians, that they will help us as much as we help them, and not an adversarial.
Yeah, definitely.
Well, we see that with with our reduction of our approach. I mean, we decrease imaging and opioids more than anybody else, right? Because of our profession, the way we see that, and patient satisfaction is actually very, very good at the acute level, right? Because we're walking along with the patient, we understand. So that symbiotic relationship needs to occur, but it's like, I think where the tension is I think people are concerned: are we going to take away from them? But we're actually adding. It's like, are we going to take away from them? It's like, hold on. Even though they have too many patients, right?
But that's what's funny. It's like that worry is really ironic, right? Because they're seeing 10% of everybody. Yeah. So what are we going to take away? The impact is so low on the whole system. Yeah. Right? I mean, it's probably bigger than the 10% because we're getting channeled to people that are like burdening the system and things like that. But there's plenty of people that are burdening the system we're not seeing because they don't want to come.
Yeah.
Right.
And I mean, if you want to know, if people are listening want to know that's real, just go into primary care and listen to what patients say about what your choice to come to PT.
It was obvious. It was really eye-opening.
Yeah, they'll tell you it's costs too much, takes too long. They don't feel respected sometimes. They will tell you what they're thinking. The people who do come, they like the service, right?
It didn't work. I mean, there's a myriad of reasons why, for sure. Because it's treatment-based approach rather than what is their real problem. I love the example of, can you shift them from going to chronic? I mean, that's a major health, gateway, right? Or path. I mean, that if you can switch them from not going to chronic, that's a major win.
Yeah, and I think that's where clinical practice guidelines are available. It's to try to prevent them, right?
I'm a big fan.
We just interviewed, somebody, and Joe God, shout out to him, right? And he says that was really, and he's one of the co-authors for the low back. He says that was one of the biggest reasons. So we're seeing a conversion, going back to the JAMA article, of about 30% that are going from acute to chronic, which is a lot higher than we expected.
It's pretty high.
Because we were thinking maybe like 10 or 15% or maybe 20 at the most. Because with just normal like chronic pain or persistent pain, we know 20% of the population have. Yeah. But it's actually 30% that actually convert from acute to chronic. And again, like what Jeff was saying, it's like stratification was really robust, but also what the advice you were given.
But it goes back to, I think, our training. So we're trained in bio. We're trained in phys, pathophys, these medical neuroscience. We got our faculty right here teaching that, cardiopulm, so the disease processes we know about. But we lose it somewhere along the line and somehow think that, and I'm going to pick on something else, that red cord is now the be-all, end-all. You hang people from a ceiling, and you pluck the little things, and, oh yeah, look, their back extensors got excited, and now it's like phenomenological, right? And now everyone's getting seen, and we've blown it.
Yeah.
Graston. Let's scrape the heck out of someone. Now, I believe the Graston literature early on when they did the rats, right? Physiology, they actually, but it's a 600-gram rat. It's not even a pound, and they're putting a human body scraping this little tiny rat. Of course, you're going to get some sort of change, but try to make that into now how much do you have to scrape that person? Because we know tendinopathy is related to abnormal tendon physiology.
Yeah.
But we also know that it's mechanical.
Yeah.
Right. So the only way to lay down more collagen is with tension. Yep. And Graston in a human is not laying down tension. Frankly, it can't.
Yeah,
you can't lay down enough tension with the Graston device.
Like the number of body weights of tension that's going through a tendon that it requires to remodel it is in the thousands of newtons.
Yes.
And
in 5,000. It's about 5,000 newtons.
Yes, I mean, gastrin's not even anywhere close.
It's not anywhere close.
Yeah.
So, in our treatment, do we contribute unwittingly to the acute to chronic transition?
We don't have. We don't have evidence of that.
Okay,
but I think what we're suspicious.
Yeah, but I'm asking, I'm thinking of lumbar stabilization, right? I think a good part of your practice is undoing that, what people have been told by their own therapist. So I'm just wondering how much of that conversion is our own fault.
But you probably clarify. So by bracing, like teaching abdominal bracing as a technique, and that's the lumbar stabilization, doing the, really what's we've been doing for a long time, which is trying to get the co-contraction of the abdominal and the rector spinae and muscles to work, and then, but that's counter, right? And this protect the disc kind of back position, right? That's what you're, I think, suggesting, and that's true. Like, and essentially what Peter Sullivan Groups has been doing, like there's some new data out that like bending the back really isn't that bad, and there's no evidence that kind of restoring motion of the back actually helps, is associated with improvement. But you could, I know Dan can talk about some stories about relaxation and what that's about, right?
Yeah, and I think Chad could put out a really good paper, Elephant in the Room or whatever, about over-medicalization. And I think it depends on the stratification of the patient. I think it goes back to measurement. And I know that's so unsexy to talk about measurements. But to me, it's not unsexy at all. It's like if I was building something, super complex, I would have to measure. And the low back pain it's complex. So if it's low or medium risk, think about it. If you're over-medicalizing them and telling them all this stuff, dude, you just made them high risk. Because now they're worrisome, they're anxious, right? They have all of this catastrophizing.
But it doesn't have to be much, right?
Yeah.
It doesn't...
It could be as simply as bringing the spine model into the treatment room and talking them about what their back looks like.
Well, what's the red about?
Right?
What's the red thing around that disc?
That's it. And now they're switched. That's how easy it is.
Yeah. And we've seen that, right? Because their imagination runs wild on what that looks like. Because if you go onto, Dr. Google and you look under disc herniation, the number one thing that comes up, honestly, is microdiscectomies and how easy it is to fix them now through using a microsurgery. Right. So you don't know how many times I get a question about disc and then microdiscectomy, but there's a longitudinal study that was published out of the Royal Society of the British Orthopedics Group or Neurosurgery Group showing that the 7-year prognosis of disc herniation is actually very good with massive herniations. And then New England Journal of Medicine did a case study on this. So again, you have to understand the literature around the disc.
Right.
And I think in a way, McKenzie had it right in that way that he says, you know what, fix your own back. Keep moving. Like, do we believe in the disc model? No. But the thing is that the advice that was given was actually pretty good, right?
And he was very against hands-on treatment, right? Remember that?
Yeah, fix your own back.
Fix your own back. Treat your own back, right?
Yeah, that's your own back.
And so I think again, it's like we're getting the updated version of some of the maybe limitations of all these treatment approaches or the way we treat things.
Right.
But at the same time, there's some really good things in it. Yeah. And I think with Red Cord, one of the good things I see about it if I can, there's a lot of interesting things about it, but the good thing is that they're exercising. And we all know that exercise is good for the back, right?
Well, they're not really exercising. But,
okay. That's fair.
At least what I've seen.
Yeah.
So they're suspending people from the ceiling. And
it's just traction. I don't know about it.
It's not even traction.
There's inversion therapy.
It's like cranial inversion, whatever.
The cranial-rectal inversion.
It's cranial-rectal inversion therapy. So
what's their claim then? That it's like a neuromuscular?
Yeah, it's neuromuscular. Well, I mean, they've got so the literature's when they publish literature about let's take the back extensors or neck or whatever it might be. They show that have increased muscle activity when they put people through these treatments. So, and then they claim that this, the reason that suspension, and I don't know a lot about it. I've read some of the articles for sure, and so it's not clear from the theoretical construct that's based in biology that works. But the phenomenology is there.
Yeah.
Right.
So what I think what we taught our back course, to me, we taught how the back works, like, and how that's restoring the flexion of legs.
That's where I want to go back to.
I know. So,
because
I guess my
people don't care about how things work.
Well, they should.
Yeah, exactly.
Well, that's not
tendinopathy
true.
is related.
That's overly negative.
Is related to an abnormal collagen matrix. That's why people get tendinopathy. Yeah. And the only way to fix it is highest load. So I'm with Andy. I don't know if people want to really want to know the underpinnings of why.
Well,
these
I was just talking to one of the students today, and we listened to the CSM modules are still available right now, and I had watched one of Chris Powers' talk and about the glute max and how the glute max can help prevent the
just hip strategy versus knee strategy.
Yeah. Well, yeah, but listen, it's like the hip, the knee valgus at the knee. Okay, but hip extension helps knee valgus at the knee, and so the students, we went through all these different strategies. How if you kind of lean forward, you're going to more emphasize the glutes versus and you de-emphasize the quad. If you kind of land with more hip flexion or trunk forward leaning, right? And that's kind of a basic biomechanic thing.
Yeah.
It's not, there is no, that's physics. It's 100% happening. And so, Chris just kind of connected for people, the idea that, hey, if you land with a vertical trunk, you're really not loading your glutes at all. And so you're losing the mechanical advantage of the hip extensors to externally rotate the hip. Right, and so if you bend forward at the knee, at the hip, and flex your trunk, basically now the glute's engaged, and it's going to naturally pull the femur into external rotation. So without doing anything at all, not even thinking about the frontal plane, you can eradicate the knee valgus that your patients are experiencing. Right, and so what's really beautiful about that is it is basic physics that kind of and muscle anatomy that explain, how to retrain somebody out of that without working on hip abduction, right? Because hip abduction it's a harder road to hoe, right, in terms of getting that to happen.
But the literature's clear on hip abduction. Chris Powers showed that for a long time. So
but they were showing that like strength and hip abduction isn't correlated to your knee valgus.
I get that.
That's the problem.
Putting people on a proximal control, hip, external rotators, and abductors helps people with patellofemoral pain.
Right,
that's clear.
Working more on the hip than the knee. Right. That's right. So anyway, I think that's all right. So but that's a great example of how, to me, what we're sitting there thinking with us talking to the student. I'm like, how do you not get distracted and stay in an evidence-based track? Because these things take thinking and they're not as quick like you. They take time to evolve and stuff like that. But
as a neuroscience guy, and I come into the world of orthopedics, it just breaks my heart to see like a lot of ortho people do operate on 1950s neurophysiology. a lot of therapeutic treatment approaches that we've used for decades are really based on an old or a poor understanding of how things work. And I feel very fortunate at George Fox. We've got a year-long anatomy courses. We've got year-long biomechanics. We've got year-long neuro and motor control. So we have time to really develop, I think, a good understanding of how things work in parallel with clinical application. But you can't. I'm really worried about going to 2 years of training for physical therapists, because what's going to get cut are these foundational sciences that therapists use so that when they go to a course, they can call bullshit on what's bullshit. And I worry that we're going to enter a time when therapists are not going to have the tools to be able to evaluate things, that they're not going to know how things work. And they're going to be totally dependent on whatever guidelines get passed down to them from someone else.
Or what course they go to. And now, you said it, right? You the hammer analogy?
Yeah.
So if you've got a hammer, and that's all you have, everything is a nail. I think that's true.
So I like what you're saying, because see, when it's a nice blend, right? Because we talked about the clinical practice guidelines and discordant care, right? And so what's interesting about the guidelines is they give you a lot of latitude.
Yeah, I'm not against them. I'm just saying that I don't want to go into a world.
Let me finish. So they give you a lot of latitude in your decision making. So they don't really tell you exactly ABC, right? They're not supposed to be used that way, right?
Right.
So to your point, it's like you have to have some problem-solving ability in the models that are represented in the guidelines, because the guidelines are built on models. Like for example, the low back pain guideline right now, the fear avoidance model is super important to understanding the psychological recommendations in that guideline, right? And the manipulation's a little bit more black box because we don't understand the diagnostic or the disease process. So that's more pragmatic, right? But the guidelines are tapping into theories that are real, and the new guideline when it comes out is certainly going to have, things on the new models of pain and neuroscience that have been evolved. And so whatever those implementation strategies are, they'll be fine-tuned by practitioners who are more deeply embedded in the theories that are driving the guideline-based treatment. Right. You know what I mean? And so that's to your point.
I don't want to go into a future where there's a select subgroup of therapists who have training to be able to be engaged in putting a practice guideline together. We need therapists who can call bullshit when it's bullshit at a continuing education course. We also need therapists, if you want to develop primary care, I'd like to know from Dan, what does it take for a person coming out to be able to stand shoulder to shoulder with a physician? That's a different kind of, we talk about interprofessional education. I've never understood, I guess PT or OT, but it seems like in medicine, that's where the real fruit is. Yeah. And so what does it take to stand shoulder to shoulder with a physician in that kind of a setting in terms of your training and knowledge?
Yeah. I think, just to kind of answer your question, then piggyback off of that. So to answer your question is, I think what really took us to the next level, and just as from our own experience here at Fox, is having Sellers, who's an internal medicine physician, teach the pathophysiology. See, what was happening is as he was teaching, I would sit there and listen, and I understood that he was a master of internal medicine, and he understood the physiology better than we could ever imagine. But the other thing that helped was then going into the clinic with him and then seeing patients together and recognizing there was a clinical practice that I could help explain to them about musculoskeletal. And so it became this real relationship between our strengths. But if you ask me what kind of courses that we really need to have a good understanding of, is I think that we do a very good job with the MSK. We're already doing a really good job with MSK. I think the challenge for people then is having a brief encounter with the patient. making decisions in 15 to 20 minutes and being done. And then being able to communicate that well with the provider. So it's the speed of like what you know, and then the tests that you need to do inside of it, right?
One of the...
So let me just go one more up from that. So I agree. I mean, that's clearly necessary, right? But the other piece is there's like, I don't know if it's confidence, maturity, what you're going to call this, but when you've decided that it's a musculoskeletal thing, or that you know it's within a certain certainty.
Yep.
And this is where I think maybe that's the issue, is like, what's that certainty? When the PA is going to say, okay, let's do an EKG. I had an EKG plan for this upper back pain, but so now that provider, you just walked in and said, hey, it's not the heart, right? And so what's your level of maturity and certainty that you can tell the provider they don't need the EKG? That level of interaction, is where the breakdown happens when we work with the PTs in primary care. They're different levels of hubris, I guess is what it would be, and just kind of background confidence, and it can be too much hubris that's ill-placed, which also happens, or it can be really, I'm technical, so I made sure that the strength was there. I made sure this was there. The rest, I'm out. I'm not going to make a judgment on the heart, and I'm not going to give you my judgment of how certain I am that it's not the heart, that it's musculoskeletal. I just did my job according to the protocol I know. See that right there, that interaction, that's where the high value is. Because basically, in primary care, one of the things that's happening is we're just helping care get delivered better, unnecessary tests not be delivered, right? And so there's judgments in there where there's two things. One is like, what's best care? And then the second thing is, what's your maturity and skill level in communicating what you know and don't know in a way that's real to the physician? And then a third level is like actually influencing the physician.
Yeah. So the second level, that resonated with me, and I think all of us. Yeah. When the physician tries to read the PT note to try to figure out what's wrong with them, and they can't understand it in any way. So going toe to toe is going and telling them in their terms, not PT terms, what they think it is. And so straight up going, and we've all had these experiences. No, I don't think they have meningitis. I think it's, neck pain. No, I don't think they're having a heart attack.
It's not a heart attack.
It's musculoskeletal. And because we can reproduce these symptoms, and we've all had these experiences.
So your question is really interesting because, let's say this musculoskeletal case. This is a real case I had like a couple weeks ago. Patient with upper back pain, and she was having the symptoms when she was sleeping, right? So what's the right training to make the PT smarter at interacting with the nurse practitioner in this particular case? Is it cardiopulmonary history and stuff? Because, pain that comes on when you're sleeping, is that really going to be related to heart disease, right? It seems like maybe not, right? Because it's more exertion, right? And so, but that's pretty simple, but that would be related to cardiopulmonary physiology and disease states, right? Or is it just professionalism that, where you're now seeing patients together in the clinic and have to bring what you know present, so what kind of training is that gets that behavior that's going to transfer into value? Because the value is the interaction and stopping the test and redirecting care. That's where the value is.
But you're not going to know if you don't have the base.
That's right.
So on this topic of training and value, I want to throw out a reason that people come into PT, and you tell me if or why it's wrong. Because we hear it all the time with interviews.
Yep.
Is this. Do you know what I'm going to say?
Absolutely.
Yeah, absolutely.
I want to spend more time.
I want to spend more time with patients. Mm-hmm. That's why I want to be a PT.
Because I see doctors only spend 15 minutes, and I want to have a better relationship with my patients.
I love spending more time with patients. Dan Kang, what's wrong with
How many times do we hear that in the interviews?
Because we a lot of PTs, when you're interviewing, you love hearing that thing. And so what's wrong with that? How does that help or hurt our future? Dan Kang, go.
Yeah, I think
I feel like McLaughlin. You don't you guys don't
well, I think that's one of the reasons why we know that there's a lot of people who in the beginning don't want to do primary care.
Yeah.
Because you can't spend time with your patient. You only see them one time. The other thing I wanted to add
that was the very first person we offered it to.
Yeah.
They said no because they valued too much the relationship with patients. So not just entry-level PTs, but PTs practicing.
So we need people that value something different.
That's right. And I would say that in primary care, you know what's king? Is actually your assessment. It's not your treatment. It's your assessment. It's what you believe.
How'd you get to that conclusion?
How'd you get to the conclusion? And
then the doctor's going to ask you.
And you have to be confident in the fact that that's conclusion. So, like, going back to Jeff's case, with someone's who think you're cardiopulmonary, I'm thinking acid reflux, I'm thinking about cardiac, I'm thinking about thoracic spine, I'm thinking about shoulder, I'm thinking about neck. Those are 5 different systems or different areas I can look at. I'm going to rule out the heart first because that's the red flag. Then I'm going to look at her GI and see what her GI look like. And then I'm going to go to MSK. And we're going to put it together, and then I'm going to come up with my conclusion from doing my physical exam.
But you might also lean on the physician to help you with the GI and the heart, right?
Or lab values or something that we didn't. Yeah, exactly.
But this is the thing. It's like, of course we would, but at the same time, could you do that alone in making some good, wise decisions? Not the right decisions, but the wise decision.
And I think, in 15 minutes.
Exactly. And I think that's what we're saying about primary care. Yeah. It's no longer about the time that you're spending with the patient, but it might be access, it might be impact, it might be innovation, it might be furthering, like the way that healthcare should be, it might be public health. There's lots of different regions that we're looking for. I don't think there's anything wrong with the PT student saying that. But are we going to give them grace enough to change in the 3 years they're here to be able to flex, right? And then I get to teach a third-year class.
I'm with you on that.
Right? So we get to teach a third-year class, and they write a paper saying they changed so much.
Yes, but should that be at the top of the list? Because it's always the first or second.
So what I think that will change when there's, the main exposure to a new applicant coming in is primary care PT. Because they're not going to see that.
They're not.
And so, to me, I had the same angst when I started interviewing patients or new applicants, right? But now it's like I just let it roll off because their main experience is them watching PTs talk to patients.
Why don't these applicants say,
I want to change the health of a community.
I want to change the health, but I love human movement. Yeah. I love watching people move. I love helping people move better. Yeah, but a fraction. Like, what does it say about our profession? What does it say about our profession? When applicants come in, they're going to spend $100,000, right, on less or more, around there,
to be someone's friend,
to spend time with patients, to charge people. Like, I don't understand how we have this profession where we're supposed to be the movement experts, and the people coming in rarely say, oh my God, I love human movement.
Can I put a positive spin on this? I think what they...
Am I being negative?
No, I think...
I don't understand it.
I know, I have...
It's their experience.
Same angst, but I guess on the other hand, it's a good thing that, people are attending PT, and that from the external, where you can't really know all the internal workings of a PT's mind as he's watching movement and all these different things. Because if you watch a PT clinic, people look and say, hey, everyone's really happy in there. They're having a great time. So the PTs are controlling the environment, creating a positive experience for people. So external watchers may not see all that machinery in somebody's head.
No, I get it. That's good.
So I think I want to have...
I don't penalize them for
I'm not
that.
sure we can kind of... But what you just said is true. Like, an applicant, if they really think that, the irony there is well put, right?
But I love what you said is, how hard it is if you're coming into a profession that you think the main reason is I want to spend time with people, and now you find out that's not part of, or that's less a part of it.
Yeah.
Well, it's interesting.
Where do you go?
We could go I'd like to go to if we could switch it to the biopsychosocial along this line, right? Because
of course you want to switch it to the psychosocial.
Yeah, but let me add to that. I think
we talked about biopsychosocial already.
Oh, have you already?
No, we.
I see in this one.
The first half hour was you biopsychosocial.
So the interesting thing is I think the primary care sounds noble and people are okay with it, but imagine if you have to do 21 patients now you're not spending time with your patient at all. Mm-hmm. Now this becomes disheartening, and this is where the burnout happens, and we've seen this, right?
That's where our students are stuck right now.
Yeah, and I think that's exactly what we have to recognize. It's like the tension is real because a lot of these students who are coming in are very, very good students. Yeah. We see their GPA, but they also have this other side, right? That they want to be relational. Yep. Yeah. And we recognize that, right? So it's like, how do we leverage that? It's like, it's okay to be relational.
They want to feel reward and good for
our experience in primary care is that PA, nurse practitioner, MD likes the relationship too.
Yeah. Yeah. And I think we are the movement expert, but if you ask me the ridiculous, I'll just tell you the ridiculous thing. PT has a brand issue. We really, really do. We have a serious brand issue. Yeah. And you
keep going.
What I mean by brand issues, people really don't know what we do. Even as an aide who's observing, a person who's applying to PT school going to drop 100,000. They don't really know what a PT does. That's the crazy thing. And if you ask the providers that, it doesn't matter if it's a PA, nurse practitioner, they don't even know what we really do. And so this is a big problem. We say we're movement experts, but isn't a personal trainer a movement expert? No. Now we're a movement expert in all the systems. Neuro, cardiac, what does that mean? So what we're running into is a brand issue, and I think we're actually in a very dangerous place because with more programs, the more not diluted, but the more that we don't know, right? So more programs happen. Now it's you got all these supermarkets that are shopping, and it's what is it where we're selling at the end of the day? And so it's our mission has to become stronger as we start going out. And so that's when I look at an institution, I wonder what the culture is.
So because it's funny, it's really, because we start with this, the PT world was really good about pathokinesiology that came out, when we were in school and everything. And that firmly put us in this, abnormal movement, kind of area and everything. I still believe in that bio mission, right? But I've kind of, I had two experiences. One is a friend of mine who had PT for his shoulder, his back, and everything. And he just smiled. He says, PT is so strange to me. It's they give me these really ridiculous things to do that actually help me, and it really shocks me. And so he saw us as that kind of thing. I thought, well, it's kind of close, right? We give them these simple exercises, and they move them out of this one zone and into a new zone, and then they're better, right? And so that was kind of a cool thing to hear that somebody actually articulated that wasn't a PT, what we do in this lay language. I thought, that's kind of nice. I liked it. But on the flip side, I've kind of, because this idea of branding, right, or education, right, I've given up a long time ago trying to explain to another provider what I do. Because besides just giving them some impressions of things, because they're not really, the amount of investment they want to make in understanding what I do is pretty low, actually. Right? They just want to use me in a way that's useful.
Helpful for them.
No, right? But they don't really want to know what I do. So my advice to students and beings is don't bother wasting your energy educating people, because you can tell them all these things, but they're only listening in terms of what their job is and their role is. And so when you think about interdisciplinary care, bringing us in the same room and treating together, see, that is powerful. Or treating side by side, that is powerful, because it's not what we do, it's what our product is, what we can produce that matters to these people, what our outcomes are. And us being able to say to the physician, they don't have heart disease. Just let it go. Stop the EKG. That's powerful, right? But them understanding how we got there, they may ask us. They may not. They may just say, oh, okay, and trust us, because they now know that we have good medical knowledge, right? And that's it, And so to me, it's just because it's like if you sit in a classroom and you're getting educated on something, you're invested in learning, you want to know the outcome. then it's worthwhile, right? But trying to educate people that really aren't in there that way, they're not sitting in that classroom, it's a lot of wasted energy. So I really like the idea of branding and that kind of thing, but I'm not sure I'm really for education. Because I don't think education, in my experience after being a PT for a long time, is that effective, right? It's more effective to work together and produce. But.
So I think from that standpoint, I totally get it. But I would say that from a marketing standpoint, we're running into some big issues from a business standpoint. Yeah. And we see this with the Gallup poll. So the Gallup poll says that they would go to physical therapy. But then when they asked who would you go to the number one, PT was actually one of the last ones. We were below chiropractor, their acupuncturist, and the physician was number one. So absolutely, but this is what's running into these clinics. If we don't really know, right, and we understand, like our product is great, but the people don't know what we're doing and where our thing is. We're all fighting for that 20%. We have 80%.
10.
Yeah,
10%.
Yeah, so then we have 90% of these people who could maybe 70% who need some type of physical therapy, but we're all fighting for this 10% because no one really knows what we're doing. I think there's a huge issue when it comes to that aspect, and I think we're missing it. And I think injections and surgery, microdiscectomy, if we go to the internet and you put physical therapy, I mean, what comes up?
Yeah, they don't even come up.
Companies come up. Their own brand, it's like these companies come up. It's not even what physical therapists do. It's not even treatments. It's these companies.
Yeah. So
we're a business.
So Dan, let me ask you this. So what do you think? So is it that the service is not focused? Like what would make us go from 10 to 20?
Access. So not direct access, meeting the person where we're at, because we've tried direct access and we've seen it from research that doesn't. So what we know in our society, where's the gateway into the medical system? It's the ED, it's the physical, it's the primary care.
Mm-hmm. So let me ask you this. So what focus would help us, how would we match our focus as providers to match the primary care mission?
You mean like the quadruple aim?
Yeah, like how should we change our focus so that when we step into primary care,
it's about these five major health conditions that are all preventable.
So which diseases we're trying to help with? So our skills and talents aren't just musculoskeletal.
Right.
They address
because that again. So it's not just the 10%. It's actually 10% of 10%. Right, because it's the musculoskeletal of those people that are seeing is another low percent.
Right.
So it becomes super micro, maybe not 10% of 10.
Right.
Maybe it's 50% of 10.
So this is really funny.
So
right?
it's narrower and narrower and narrower.
So
we should broaden it.
So this is really funny. So that's true.
But broadening dilutes the brand more.
But the branding is a belief. Right, so it's not necessarily. It's not a treatment.
Oh, this is good. This is a Nike. This is the Nike. This is the Nike thing coming in.
Branding is a belief of what you're actually doing, not the product that you're doing.
So let's just stay there for a minute because I like this because why are we? So there's a big question here, and I don't know. I want to talk about it. Right. So why are we not in that list that you talked about?
Yeah.
Why are we so low when we have so much skill? And I would argue that I teach biomechanics. I've been a PT. I'm really proud of us. We work really hard. We have a lot of knowledge in musculoskeletal. That's extraordinary. So why are we so low on the list, right? And so, I would argue it's because we do disease-specific care instead of person-centered care.
We do.
I think that's a big part of it, and I think it really plays out when you try to transition to primary care. And this is kind of what I was trying to ask you. Is it's like we aren't really focused on the person. We're focused on just the problem that we want to treat.
Yep.
Do you know what I mean? And so,
the problem that we want to treat and the technique that we want to treat.
We want to use, right? And that gets back to, I think, this whole thing about dry needling and stuff like that. It like we get married to the treatment and the technique, and we forget the person.
So,
right?
So I agree with that. I think the low hanging fruit, honestly, and maybe it's for some people it's not low hanging fruit, is actually treating the MSK. What you're saying is that we got to exceed expectation beyond the disease specific and actually treat the whole person. But I would say that the low hanging fruit, though, is like we have to treat the MSK because that's what they expect us to at least do that. But if we can do cardiac with that, with like helping with hypertension through exercise and movement, that's like exceeding the expectation of what we're doing.
But let's just like face the challenge, right? So Dan and I are lucky enough to be involved with a rollout in primary care here in Oregon. And so without broadening what we do, we are now facing a rollout where they're going to endorse physical therapy, PTs in primary care full on as much as possible. So,
but it is broadening what we do. But so let's be clear with that.
But let's do the numbers. So we're just restricting to primary care.
Right.
Nothing, and my MSK, no other problems. Right. Just MSK for now. So that's what I mean by broadening. Not going to cardio, not going to hypertension or anything like that.
But what did we do and how would we broaden that care?
You mean in MSK?
Go to the numbers. Yes.
So we'll go to the numbers. So there's 15%, between 15 and 20, I guess, is the statistic for this particular health system, which in a year is going to, I think it's like...
15% of what?
Of all primary care visits.
Total visits.
So in this particular clinic, that's the current numbers from last year or whatever it was, which tallies in a year, given the number of primary, over 20,000 visits. So right there, even if you try to cover 50% of those visits, and then you get engaged, which they put some incentives to make that happen, they're right now like trying to figure out like what the heck are they going to do, right? Because that's 10,000 visits. And so now they've reduced it down based on different things. Now they're trying to think about like they're currently on their current primary care delivery mode. I think they're on track to do 2,500 visits with their current staffing. So they would have to, multiply up by 4 to cover the service, right? Which they're having a hard enough time just filling the positions that they have, right? So, and they haven't done anything else in any other part of the thing. So my point is it's like, this would mean we would need to like figure out how we can be accountable for those people that we're being asked to see, but also not see some of them. And so to Dan's point, what's the key thing to be able to do here to triage ourselves or spread ourselves out among these people? It's assessment. Mm-hmm. It's assessment all day long, right? And it's also helping, interacting with the primary care providers. So maybe they can even do some triaging so that we don't get seen by those people. But that means we have to like be in their same mission.
Yeah.
So that they hear us when we talk to them. And see, that's what I mean is it's like, now if I sit with that provider and we're in the same mission, learning the same things, we have the same goals, now when I have education, it means something. Yeah. Because we're like on the same team. Yeah. Right? If I'm trying to educate them and I'm over here, they're listening in a different way. And so that doesn't...
It's education oriented towards assessment.
No, or oriented toward person-centered care from MSK problems in primary care.
Yeah, but you asked him earlier.
Well, it wouldn't be about assessment.
How do you push into the 10%?
Biopsychosocial assessment.
Yeah.
But don't you think though, like the better your assessment, most likely it's going to affect how good your treatments are?
Oh yeah.
I mean, right? Right. I mean, if we think about it, right?
Yeah. General Patton used to say, "You never let your enemy pick the battlefield." Mm. And that's what you're doing with assessment is you're picking the battlefield or not.
Yeah. Oh, I like that. That's really good.
Yeah.
Yeah. Because that's how you increase your wins.
Yeah.
You pick the right battlefield.
You're talking about like that. So I think one of the
question.
Yeah. So I think one of the biggest ways that we get into 10%, I think we're answering it. I think you just got to go where the people are. So the people aren't downstream. They are not downstream. I'm telling you right now, because they're down the stream. You have to be upstream. And we know that because in our healthcare, right? So it's like the funnel is being clogged up. So what Jeff is explaining to us is like there's all these people, like 10,000 people that needs to be serviced for the MSK. We're not meeting them there. So they're getting funneled through all of these things.
We're not even interested in that. So that's what I think is by showing up this highly specialized, expensive, extravagant service, dry needling, manipulation, all these gastrin, all these highly dependent, time-consuming interventions that are modulation. We're not even interested in 90% of these patients that don't want those things. They want something simpler, more practical, that doesn't require them to come so many times. more about other aspects, other ways of treating it.
So do you think that those people don't need physical therapy, like continued physical therapy in primary care?
No, I think they can benefit from us.
That's right. So why is it
or a one-time treatment?
Yeah. So, but why
so not necessarily continue, but at least a one-time to get them on the right track.
So why are they getting clogged up then? Why do you think they're getting clogged up in that area then? Because we're not seeing it down. We said it's 10% downstream.
That's what I asked you.
Right.
Yeah.
Why
so I'm throwing it back.
We don't know. Well, you mentioned.
I think it's. I really think that our main problem is that by getting into all these our main problem. We have so many successes, so I'm just signing
with you.
But I think one of the ways that we could be so much more impactful is by going to this person-centered place, meaning that if we blend this bio with psychosocial, what we're going to find out is some of the things that really excite us, like the dry needling and stuff like that. If we get really good at the psychosocial, that's how we're going to find out that people are going to tell us, hey, I didn't really need that, or that's not such a big deal to me. And you know, like, I'll just go back to one of my...
Yeah, I'm having a hard time. I'm having a hard leap with that one.
But. Well, let me just give you an example. So I got through with my manual therapy stuff, and I was treating a patient, and somebody came in and said you should ask patients more directly and engage them. And this is years ago, 20 years ago. And so I had this young woman come in, and I did, she had a sacral, you know, what to me at the time was a sacral, you know, malalignment. And so I did all the, you know, muscle energy and high velocity thrusts on her sacrum and realigned her and did the, you know, sit test, and her malleoli were lined up and standing was lined up and all her pain went away. Fantastic outcome. And I said, and she full range of motion, everything you could imagine that defines a perfect outcome after a manual therapy treatment. And so then I said to her, I says, okay, and I'm thinking I know the answer to this, but I thought, watch this. I'm going to try this new approach, right, of communication skills. And so I says to her, okay, so essentially the new evidence says that you have more pain relief and you know, kind of better short-term outcomes if you get this type of treatment that you just got. And, you know, you'll feel as good as you do now, you know, and that'll accelerate your recovery. But at the end of the day, after 4 to 6 weeks, you're going to end up in the same spot. You know, you'll still get, your back pain will still go away. You'll just have a much better experience in this 4 to 6 week period. So we can see you either, you know, a couple times a week, or once a week, if you like, or I can recheck back with you in 3 weeks. Which would you prefer? So what'd she say to me?
Well, it's got to be, I'll see you in 4 weeks.
I'll see you in 4 weeks. And I was like, crushed. Right? But it was like I gave her choice, right? And her autonomy was, see you, buddy.
Yeah.
I can live with the pain I have, even though she had told me, you know, she had a 5 of 10 pain, all this kind of stuff. And she had the absolute perfect, I couldn't produce a better outcome, even to this day, right? And she was fine as long as she knew that, right? And I was like, oh, snaps, as Dan would say.
You know? But since that's the difference between managing and then treating something. You just talked about managing pain. Managing someone who has low back pain versus treating it, Jeff.
Yeah.
See, when we say we treat it, we think that there has to be certain dosage. Yeah. Right? Instead of managing, it's like you're meeting the patient and they're like, that's enough. I'm good for the next 3 weeks. Let's see how that goes.
Right.
And to answer that 10% in primary care, our job is not to increase referrals to PT. Our job is to give access to patients who need care to help with the quadruple aim. That's how you get it. But even if we saw them one time and they had a good result or they had a touch with a physical therapist that was meaningful to them, going back to the person-centered care, say that's enough. But when they have back pain or a knee pain or ankle pain, they're going to more likely think, oh, physical therapy. You go down the stream, they're like, well, I don't need to see the PT. I'll just go to my orthopod. Or I need to go to my primary care because they're going to give me an image. Yeah. So our whole view of how physical therapists change now because the direct pathway now is to physical therapy. And now their approach is like, oh, I'm going to go see my PT. That's going to open up direct access. It's going to open up seeing people in primary care.
But don't you think it's because of the person-centered approach? Because it's like, okay, I'm just going to go check in, and I'm going to get some reassurance, I'm going to get some advice.
So define person-centered care. Define person-centered. Yeah, I think that might be helpful for some that haven't read New England Journal and all these other places.
So essentially,
right?
it's just focused on, instead of being focused on their knee problem and fixing their knee, it's whatever their movement, in this case, let's just do PT, specific person-centered care. Whatever their movement or lack of movement, how that's affecting their life, we would be focused on that, irrespective of the cause. Just what kind of movement problem are you having, or is really, so if it's diabetes, you're not moving enough, so you just need more endurance and, weight loss kinds of things, or just, physical capacity. If it's knee OA, well, then it's just moving to modulate pain and then to maintain ability, so you don't lose function, right? And so whatever kind of movement related issues they're having, then we're just focused on helping them stay active. And that's really the main thing. I mean, would you define it similarly? Or
yeah, I go with your definition and then what's been in New England Journal of Medicine, the things that we've all read, right? And I think for people who are having a hard time around it, it's kind of like where precision medicine's going. It's kind of like, precision. It's like understanding the gene theory. It's like person-centered is just saying that the patient, it's like whatever the patient sees as the threat that they may be feeling or the concern, right?
So to put some more meat behind it, that could be biologic or psychological. So the thing that's not, the reason they're not moving is it could be just beliefs, or it could be fear, right? Whatever's causing them not to move. Yeah. So, and that's really the expansion, right? Because the expansion is we already have some of the biology.
We missed it somewhere. People believe patient-centered care is psychosocial.
You said patient.
Person-centered. Person.
So, that's, see the difference. See, it's like, because it means it could be.
It's the same thing. People believe that person-centered care means psychosocial. Yeah,
because you want to be a physical therapist, not a psychotherapist.
That's part of the challenges right now, is because people-centered care means psychosocial. I want to know what they believe.
Should you be doing biopsychosocial, and that's what you're saying, right? It's biopsychosocial. So it's like, so let's do, like, what's the mechanism? So I've been hot on this, because basically when people feel threatened by being psychosocial, they're afraid that we're treating...
Or not threatened, or they go all in and forget the bio.
Either way.
That's where we're at right now.
Either way. So some people are threatened and some people are only treating it as a bio. Where was I going with that? Yeah. So the point, though, is that it's just recognizing that movement, right, is essential to health, and that whether the things that impairing movement is psychosocial or physical, like biological,
right,
we're interested.
Right.
Because that's our expertise. And so what we're just saying is, like, when you say person-centered care, you're just saying, hey, I don't care what's causing them to be limited in their movement or what's impairing their movement for health. I'm going to use whatever approach gets them to move, and I'm not going to make it. It doesn't matter if it's a home exercise program or not, if it's physical activity or it just helps them deal with it's breathing to deal with emotional distress. That falls within PT, and as long as I'm focused on physical function, then I'm doing PT. And see, that's...
Yeah, if you just give them some assurance, hey, you can go back to doing X, kayaking, walking, whatever it is, and there's a low chance that you're going to exacerbate the problem. Like, that's a big help for them.
And what's weird is the number of times that we experienced the positive effects of reassurance or clear understanding in primary care is remarkable.
Yeah.
And the difficulty that other providers had in providing the same assurance is also remarkable.
But you don't have to give them Theraban to feel like you're doing something. No. And in fact, what you could be doing is undertreating them instead of allowing them to regulate their own ceiling for what it is that they're able to do.
And I think the pinnacle of it, and we know this, is shared decision making. It's making it help, kind of coming to a point where you guys are sharing that decision. It's kind of like when we ask someone, like, why are you here? And they tell you kind of their cause. Now, once you have that shared decision making, you have this clinical reasoning that maybe the patient doesn't at that point. Then you can have education and communication around that. And I think that's really where like people say the person-centered care is most important, is the shared decision making. And it doesn't mean that the patient drives that. It's like you're coming to an understanding together. Like, this is the most important thing to me right now. And then you'd be like, okay, so then what can we do to address that, right? And so I think people are concerned that you're not going to have a say. No, you have a say. It's because it's shared, right? The concern.
So I would just to kind of illustrate, I mean, there's so many illustrations. I know you could identify them too, but like a simple one was one early on that I had, like with a patient in primary care. So she had low back pain. The doctor asked me to come in, and essentially, you know, she was a unilateral, about L5-ish SI, kind of PSIS area, you know, and she'd had it for a while, and she looked very upset, and she says, you know, anyway, so I came in and I says, basically, tell me what you're afraid of. And at the time, for whatever reason, that's how we were asking about pain. It was, we had just done some neuroscience pain education. We were short-circuiting that because we only had 15 minutes. And so I says, well, tell me what you're afraid of about your back. And then I also want to focus on preventing disability. And so she immediately says to me, told me the story about her father, who was, you know, disabled his whole life with back pain. And she says, I'm really afraid I'm going to be like my father. And that's why I'm in here today. And so I says, well, I can 100% assure you that you're not going to be like your father. And here's some exercises, and you do these. It shouldn't get any worse, and it'll probably feel better with these. So we went through that. And then I remembered I'd forgotten to have her fill out the start back tool. And I was like, dang it, because we were supposed to do that, right? And I was like, I was such a bad documenter and assessor, right? And so I said to her, so can I have you fill out the start back tool score thing? And she started taking it, and then she looked at me. She says, am I supposed to fill this out from before when we met or from after when we met? And I said, why are you asking? She says, because you changed how I was thinking about my back, and so I don't know how to fill this out anymore.
Yeah, nice.
Yeah,
and so it's like,
that's good education.
Right. And so I think, you know, but the interesting thing is movement was involved because she had to move around during the eval, and we had to ask the questions in a direct way so that she revealed. And so,
I mean, that's a great example of patient-centered care. That's what, at that time, she was...
Person-centered.
Sorry. It used to be patient. Now it's person. Person-centered care.
Right.
Because that's what she was.
So it was her issue.
It was her issue.
And once we had dealt with her issue, she just made it clear that once we had dealt with her issue, she was fine. She was reassured sufficiently, at least at that moment, that she was fine and ready to move forward and not worry about it.
Yeah, I've seen hundreds and hundreds of cases this way.
Yep.
And again, it's like, I think the thing that convinces them is that, you know, for me, it's like when Sellers and I was seeing a patient together, Sellers, I wasn't there, or I was coming in later, he brought him in, he always tells a story, and this patient shared decision making was, I need imaging and medication.
Shouldn't be person-centered?
Sorry, person-centered. At that moment, he was a patient, but he's person too now. Right?
They're all patients.
That's right. So
we gotta go.
Yeah, perfect.
Right.
Perfect. Go. Get out of here.
Yeah, we gotta go.
We got enough.
So we have to... Actually, I would sit here. Sit here.
Too bad.
We'll stop it.
Okay.
Is this all?
No. But we'll do a,
just
want to, thank everyone for being here, and it was supposed to be kind of a Mythbusters, but it turned out actually to be a Mythbusters because we're focusing on the wrong things. We're not focusing in on the overall health of our communities in a way that can be meaningful to the large health challenges that are in our communities. So, thanks everybody.
Thanks.
Thanks,
you. Dr. Cuddeford.
Thank you.
Associate Dean.
Exactly.
Wow. Great topic today. Great conversation today. Thanks for listening. Thanks for tuning in. And just make sure you're connecting with us in some way, whether it would be liking or subscribing. You can connect with us directly, and be sure to visit our website, motifcenter.com. And if you want to be featured in our Q&A, send us a question. We'll be happy to answer that in our Q&A session, and let us know where you're coming from.